let me introduce you um, Dr. Flavia Riccardo. She comes from the Italian National Institute of Health in Rome, Italy. She's an experienced researcher in the infectious disease epidemiology unit with a demonstrated history of working in this field. She's skilled in epidemiology, lecturing and prevention. She has a strong research professional she has a PhD focused on infectious diseases from the University of La Sapienza, Rome. Dr. Flavia Riccardo brings us the very up-to-date issue of the COVID-19 epidemic response. She's going to speak about from data to action, epidemiologists and decision makers in the management of the national COVID pandemic response in Italy. Welcome, Flavia.
Thank you very much for this lovely introduction. Can you see my screen?
Yes, perfectly.
So first of all, I'd like to thank you for this opportunity to be with you today. And just building on prior presentation, I think it's really amazing how what was just explained by Professor Cocco resonates with me, even though I come from a completely different background, because I'm an infectious disease epidemiologist. And so I completely relate to what was said in terms of the interactions of the different communities and the complexities, especially around uncertainties and around accountability and trust that were mentioned earlier. And I'm going to build on that to bring you just an example. And what I'm going to focus on is the link between the data and
Flavia, excuse me for interrupting. Can you please speak closer to the speaker, please, to micro?
Is that better?
Yes.
Okay. Thank you. So I'm going to try to describe from the perspective of a scientist the link between data and outbreak management in Italy during COVID-19 pandemic response. And what I'm going to do is, did you see the change in the slide?
Yes, Flavia.
Oh, good, great. So just going to put this a little bit in context. So as you may know, Italy has been severely hit, like many other countries, by the COVID-19 pandemic. So as of yesterday, we counted over 4 million cases of laboratory confirmed infections. Of those, over 400,000 cases that have been hospitalized, with almost 14% of those in intensive care units. And we count, unfortunately, over 125,000 deaths related to the virus SARS-CoV-2. And in Italy, the outbreak started rather abruptly in the context of widespread local circulation. We were the first country detecting this local circulation in Europe. And what I will try to explain to you by telling you the story of this outbreak so far is that actions were actually largely driven by data, but this data was sometimes incomplete or uncertain or limited because this was a new infection caused by a new virus. And one difficult thing I learned also personally is explaining uncertainty and explaining what you don't know to a decision maker, because it's the hardest thing to do, or even a risk communicator when they're trying to develop messages for the population. So I'm going to split this talk in 3 moments. So we had a first acute epidemic phase in Italy starting from the end of February until the beginning of May 2020. Then we had a transition phase. That means that the cases went down. We didn't have an emergency anymore. We had the national health system that was dealing with the cases without being overwhelmed. And this went from June to September last year. And then we had another increase in cases like the rest of Europe from October until May. And now again, we've entered another transition phase in the epidemic. So I'm going to split this up in these 3 big moments to see how data grew, how the decisions were made, and what kind of instruments we tried to develop to translate data and the complexity of data. And I think Professor Cocchi explained that, do I really have to explain the model I'm using to calculate my RT? for example, into information, and that information that can be used to make decisions. So this is our very first phase of the epidemic curve. So this is data as of May last year. Just to point to your attention, when you see these curves, you will see some gray bars and some darker gray bars. And the lighter ones are the cases by the date of symptom onset. And the darker ones are the same cases, but they're reported by date of diagnosis. So we will have some cases that were diagnosed at a certain point, but their symptoms actually had developed much earlier. Okay, so that's why you see the lighter gray bars going further back in time compared with the darker gray bars. This said, so we had a moment in Italy where we didn't know that COVID-19 or better SARS-CoV-2 virus was circulating. Then we had a moment in which it was circulating, but we didn't know, which is where all the lighter gray bars are. So the patients that were later found reported that they had symptoms at that time, but we didn't know. And then we had a moment where it was detected and it was quite clear that the virus was now circulating rather broadly in the country. So there was a surveillance set up for severe cases of COVID-19, so severe pneumonia. At the beginning, this was what was believed, that this was causing a severe disease. That was set up on the 22nd of January, and the laboratory network capacity was stepped up because, again, a new virus means you have no tests. And we had to develop methods to try to confirm in a laboratory whether this was this infection or not. And then from after the 20th of February, when the first locally acquired case was found, there was a shift in the surveillance. So it became a surveillance of all laboratory confirmed cases, regardless of whether they had pneumonia or not. And so the story starts on the 22nd of January. So at the same time when the first system for surveillance was set up, Italy nominated a national task force under the coordination of the Ministry of Health to deal with SARS-CoV-2. At the time, it was called differently, but we'll use this the same name throughout the presentation. And there were some measures at the end of January regarding flights, direct flights from China. On the 31st of January, Italy declared a national health emergency because of this virus. And about a month later, on the 20th of February, we had our first locally acquired case in a city called Codogno in Lombardy. Following that, there were a number of progressively strict restriction measures, first around the Lodi province area where the case was found, then with red zones being extended to Lombardy and to the Veneto region, until on the 4th of March, we had our first national level physical distancing measures with the closure of the schools, which then led to the national lockdown on the 11th of March, that then was protracted and made more stringent in the following day. So as you can see, it was relatively fast for something which had never been done before. So restriction of movement and of liberties of people to this extent is unprecedented in Italy. And it was, I think, when you look at it that way, it looks like it was happening very fast. So let's have a look what the evidence was at that time that was supporting those actions. So the first thing I should say that when we look at back in January, the first mission of WHO, after which human-to-human transmission was confirmed, although the extent of it wasn't certain at the time, actually dates to the 21st of January. So before that time, it was uncertain whether this virus could actually be transmitted between humans. So it could have been something like the ordinary avian influenza cases we find, which are sporadic. We find them occasionally, but they're not well transmitted in human people, and therefore they don't have a potential to spread that well. And at the same time, ECDC was assessing that transmission between the European Union had a very low risk. So at the time when they nominated the task force, there really wasn't much evidence in terms of what was going to come later on. The first meeting of the Emergency Committee for the International Health Regulations on the 23rd of January did not declare a public health emergency of international concern because there was not enough data. And it was only on the 30th of January that this would be declared, which is the day before Italy declared its national emergency. So I think one thing I'd like to show is that there seems to be quite a nice correlation between the data that was being developed over time and the decisions that were made. One question is whether, we found, and then this was the main issue with us, we found this virus circulating widely when we found our first locally acquired case. So we had two imported cases in Rome at the end of January in people coming from China. And then we found some cases in Italians returning to Italy. But in Italy at that time, we had the national surveillance activities going on. And this surveillance activity looks at syndromes, influenza-like syndromes. So we're not looking for influenza virus, we're looking for flu symptoms. And at that, the 2019-2020 season is the red curve you see here, while the dark blue is 2018-2019, and the green curve is 2017-2018. So there was nothing happening in terms of flu-like illnesses that was different in 2019 or the beginning of 2020 compared with previous years. Actually, we had a low season compared with previous years. So we didn't really have much in terms of evidence that this was circulating. And this was also why it was such a big surprise when the first locally acquired case was actually linked, as you know, as things evolved and as we learned more, to a widespread circulation. We thought at the beginning we would be able to contain it. So there were some aspects that we have to think about, because some of these stories, when you look at it on hindsight, it gives a bit of a perspective, which is a bit different to what you had at the time when you were making those decisions. And I think there's a nice paper from the Harvard Business Review that talks about cognitive biases. And it says something which I relate to in terms of my memories of that time. So in the early stages, the COVID-19 crisis in Italy did not look like a crisis. So we didn't really have that many elements of alarm before the first locally acquired case. And a lot of the decisions made, including the state of emergency, were met with skepticism, both by the public and by some of the policymakers. So, and this also is true. So if we look at the newspaper articles of that time, you will find that also the scientific community was largely divided on what the impact of this virus would be. There were some people saying that it was going to be the pandemic of the century, and some people saying this was nothing more than another kind of flu. So I think this is something we have to think about when, we look back and we say, yeah, on hindsight, probably it was good that the emergency was declared, but at the time there was discussion on whether this was the case. Well, definitely when it hit really hard. The areas that were hit by the disease were, their hospital services were overwhelmed very rapidly. And one thing that I think should be also mentioned is that population resilience was also exceptional during this first response phase, which again is something we didn't know to expect. We had to make exceptional decisions, take exceptional measures as a country, and it was quite surprising to see the level of commitment and endorsement of the population. Also because the disease did not hit the country in the same way at the beginning. So the northern regions were much more involved and had a lot more transmission compared with the southern regions. And if we look at these two maps, you can see in pink, the age-adjusted attack rates per 100,000, and on the right, the simple number of cases in the first period. So starting from the 28th of January with the first imported cases, and then from the 20th of February, 31st of March, this is where the local transmission was really happening. And as you can see, there were a lot of regions that were affected, but mainly Lombardy. We're talking Emilia-Romagna, which is so if you can see my cursor, this is Lombardy, this is Emilia-Romagna, and this is Veneto. So these were and Piedmont. So these were the mainly affected areas in the very first part of the epidemic. And as some researchers mentioned on a paper in Frontiers, it was an immense challenge. Just to give an example, Lombardy, in 18 days, they saturated over 60% of their intensive care unit beds only for COVID-19. This is something that never happens. only for one disease. It was something unseen before. And another thing about context that I think it's important to mention about Italy is that we are a decentralized country when it comes to health, which means that there is a certain independence in terms of the management of the healthcare system in Italian regions. We have 21 Italian regions and autonomous provinces, and they adopt different models. So for example, in this paper, there was a discussion about the fact that in Lombardy, there was a hospital-based model. In Veneto, there's more a territorial-based model. In Emilia-Romagna, is a combination, also in Piedmont. So you will see different impacts in different...
Flavia, sorry, can you say more close to the microphone, because we are, yeah, okay. It's, okay, thank you.
Is that better?
Yes, yes.
So in terms of effectiveness, so what we're looking at here is the reproduction number. So when we look at an infectious disease, basically, we use mathematical modeling to look at whether it's being transmitted. So how many cases are being generated from an index case. So basically, just to make this, to simplify things, when your R is above 1, it means that each case is generating more cases and your epidemic is in number of cases is increasing, your epidemic is expanding. If it's below 1, the number of cases decrease and your epidemic is receding. If it's equal to 1, it's stable. So at the beginning of an outbreak, when there are no measures in place, we talk about R naughts, which is the natural capacity of a pathogen to be transmitted. When we start putting measures in place, of course, this is going to decrease, and we're going to talk about RT, so the ability of the transmission of the pathogen with the mitigation measures in place. So we can see that, you know, the natural transmission in Italy at the beginning was around 3. So 1 case on average generating 3 cases, which is quite a lot for an infectious disease. Then we had initial measures, if you remember, that were local. This brought down this transmission early on, and then the lockdown came. And so in basically the violet red are RTs are calculated on symptoms, so basically symptomatic cases. The blue is on hospitalized cases. We can see that both go down, and they go below 1. Whoops. They go below 1 around the end of March. So 1 month later, we already were in a situation in which the epidemic was decreasing. However, the number of cases was really very high. So before you see a very low number of cases, it takes time. It's not something that happens immediately. And then we had our transition phase, which we started to reopen things. And then you can see, you know, the transmission started progressively to increase until the end of the summer. So what did we learn? So the first thing that science told us about this disease is that we had a problem in healthcare settings. We had a huge impact on healthcare workers. There were really high case fatality rates in long-term care facilities among the elderly. Older people, people with existing comorbidities were those at higher risk of dying for this disease. Transmission in households was a major amplifier. And then we later learned that this transmission was actually happening through super spreading events mainly, which is very different to flu from a technical standpoint. So it was behaving differently. So as a policy input, also for internationally, there was a lot of attention to contact tracing, which wasn't easy, especially considering the rapidity of the spread at the beginning. But also we learned also from the curve I just showed you how rapidly physical distancing, so keeping people separate, was actually impacting on transmission. So it was working. We knew we needed to prioritize fragile settings. We needed to optimize the logistics and the availability of personal protective equipment, of respirators, of other materials to cater for the emergency. But we also needed to protect our healthcare and social workers. This led to a remodeling of the healthcare system. As was mentioned before, we need to identify legal mechanisms to do this kind of work. And also, I think very early on, we found that lockdown was not sustainable. And this didn't come from health data. This came from economic and social data. So we knew that, okay, we could have done the first lockdown, but whatever was going to happen later on, we were not going to be able to redo the lockdown in the same way. So part of the expansion had to do with the funding and reorganization of the healthcare system. Also expansion of hospital bed capacity, expansion of human resources dedicated to contact tracing, to testing, and so forth. And this is just to give you an example of this. So these are the ICU beds. And in yellow, you see the beds that were available or were available before the emergency. And in blue, you can see the flexible increase during emergency of hospital bed availability over time. And you can see how they increase typically during the first wave, and then they go down during the transition period and start again during the fall of last year. So there's a flexibility in catering for the increased needs, which was set up to face this emergency. So that's what I talk about when you say remodeling your system. So it's a way of making it resilient to what's is happening. Another thing, of course, was infection prevention and control. So how to avoid the infection being transmitted in hospitals, in long-term facilities, in elderly homes, in other contexts, or in the family. But also other activities like how am I going to test? How am I going to tell people what kind of methods we should be using? How should I treat my patients? What should I tell the people? So there was a lot of work being done on guidance and training. And Italy adopted a strategy that has stayed the same from the beginning. And I like the way it was described by this journalist, Coelho. He talked about the hammer and the dance, which I think is a very effective way of telling the story. So the hammer is a lockdown. So they started with very severe measures to bring down the curve. And then the dance is what we did from then on. So when we started reopening, we've started shifting until vaccination arrived, and we're looking towards a different perspective to controlling the outbreak, which is not only the distancing part. So this is what happened afterwards. So we talk about May. So we had a transition phase. As I said, cases started going down with the lockdown, and we started reopening progressively. So this was a 3-step approach every 2 weeks, which is not by chance. The incubation period of this virus is 2 weeks maximum. So the reopenings were based on the incubation period, and we were looking at how things were going. It was difficult to plan. We didn't know. So we checked it. So we went monitoring, and we opened progressively. And we also started a monitoring system conducting weekly risk assessments. And I'm going to go into that a little bit because that's an example of translating complex data into information. So during the transition phase, there was a gradual reopening, but those were strongly defined by guidance. There was stringent distancing. A lot of investments was made by private entrepreneurs to ensure that they could reopen restaurants, facilities in a certain way. There was a lot of investment on the resilience, as I said, of the healthcare system, enhancing the monitoring capacity, and a lot of training guidance in a context in which transmission decreased. We didn't have the emergency situation in the hospital services anymore. But what we had at the same time, we needed to, in a context in which there was an improved data completeness, because of course, when you have a big emergency, the problem is also the data is not brilliant, right? So the moment that things get better, also your data gets better, more timely, more complete. The testing capacity increased. So suddenly we were not seeing the tip of the iceberg anymore. We're starting to look at something a bit more consistent on the number of new cases that were being detected. We didn't have evidence of uncontrolled transmission. We didn't have an overburdening of the hospital services. We had an increased resilience. As I said, there were a number of factors set up to increase the strength of the healthcare system as a whole. And it was a time to invest in preparedness, which is what, again, was mentioned in the previous talk. So we invested on how are we going to prepare for the next wave? And again, if some of you have seen the debate during the last summer, again, also the scientific and political communities, they were strongly divided on whether there's going to be a second wave in the first place. And it was also a time to systematically translate data into action. And this is an example of this. So we developed a mixed method assessment, so mainly quantitative with a few qualitative indicators that provided a categorization of risk for each region, each week of having an uncontrolled and unsustainable epidemic. And this was regulated through a law, a decree of the Minister of Health with all these indicators defined. They have two algorithms for decision, one looking at probability. So they're all indicators that revolve around transmission. So increased cases, increased RT, and so forth. And the other one is on impact, which mainly looks at hospital services overwhelming, both general and ICU services. And for each week, each region has a categorization for each of those algorithms that then comes together in the matrix that puts together impact and probability. So at the end of the day, every week for every region, we have a risk. Is it low? Is it moderate? Is it high? And this is something which synthesizes in a single word a complex number of data elements. Another thing we did was we looked at scenarios. We used modeling to look at, what's going to happen in the autumn. And based on that, we had preparedness activities, checklists, lessons learned from the first phase, and then the readiness. So what comes just before. So a strategic plan, so how we were going to face the autumn wave, looking at scenarios, looking at the risk levels, what kind of actions. And this is what it came up to. So we have started having this monitoring by week from the beginning of May. So every line in this colored section represents a region, and the green is low risk, the yellow is moderate risk, and then you have the moderate risk with a high probability of moving to high risk, and situations in which the risk was not assessed because of data quality. And what we can see overall is that progressively, following the end of July, more or less, the situation was changing in Italy. We were able to track that. Cases were increasing. And then we were able to map when the acute phase started rather precisely. And then it continued to monitor the outbreak. So if we look at this is the risk level as of March, and you can see how it follows quite nicely the peaks of the outbreak. And you could have that with a relay of 1 week in the data. So the data was consolidated the week before and provided, and it's publicly available. So based on that, from November, beginning of November, as cases escalated, as you can see, rather steeply, decision-making took an automatic decision approach that was data-based. So they looked at risk assessment, they looked at the RT, they looked since January at the 7-day incidence. You will see in January, we had a problem with the variant Alpha emerging with a higher transmission. So there was a modulation of the decision-making process to account for the changing virus. And we looked at the effectiveness of that, and we were able to quantify the reduction in RT in the different color zones. So we found that if you were in a yellow zone, you had a certain reduction. If you were in an orange zone, you had another reduction, red zone, a higher reduction, and that all of them pretty much, at least in the fall of 2020, brought our RT below that one. That means below the epidemic threshold. So we were able to document also the impact of the measures. And this is what it looks like, again, if we look at the red line, which is transmission by symptoms, the blue line, transmission according to hospitalization. We can see that we had a number of entry position and screening provisions in the summer that around the end of the second half of August, we had a number of cases increasing because people were returning from holidays. We had a number of clusters related to nightclubs, for example. But we managed to keep it down in a moment where Europe was pretty much increasing everywhere. And then finally, we had our first epidemic alert at the end of September, and then the epidemic was announced officially at the beginning of October. They had additional mitigation measures, the first national level measures, as I said, with all the color zones, and the 3rd of November, and then the RT going down again below threshold, so that most Italian regions actually de-escalated to the yellow area at the beginning of December. Vaccination happened then, and that was a huge aspect. From the 27th of December, the whole of Europe started their vaccination campaign. And just to show you, on the left, you have vaccination coverage by age group, in which you can see in orange the proportion of cases that are pending second dose, and in green, those that have completed their vaccination cycle. As other countries, we prioritize the higher age groups because they're more fragile and prone to severe illness. So you can see that the vaccination is relatively satisfactory in terms of coverage for the older age groups. And now we're moving to try to increase coverage in the younger age groups. And then on the right, you can see just an example of some of the reports we publish on impact. So we look at comparing the ratio of incidence, so the number of new cases in the population, between vaccinated people in the first 14 days. So we know that in order to have an effect, vaccination needs a time frame. So this time frame is around 14 days to have the immune response. So we compare these same vaccinated people in the window in which they still have to mount their response and afterwards in time. And you can see that the ratio of the new cases per 100,000 decreases. And this is a proxy of the impact of the vaccination, which changes your likelihood of getting an infection. So your population is changing. At the same time, though, the virus started to change. We started to get these variants. So there was a lot of work being done to try to increase the capacity to genotype and to sequence viruses, which is a very complex and costly activity. So from February, we documented that the so-called UK variant, the Alpha variant, was prevalent. And then there was a gradual emergence of other variants. And we found that this Alpha variant was much more transmissible. So it was more likely, it had a higher transmissibility, which means that if the original one was 3, this was 50% higher. And then, the decision-making process shifted in May, very recently. As you can see, the criteria has changed, but they're still data-based. So here now we're looking at incidence and occupancy rate. So the point is, decision-making may modulate the kind of data it decides to use, but it was still pretty much data-driven. And this is my last epi curve showing the situation as of yesterday. So as we said, there was an acute phase, there was a transition phase, but then we had a second acute phase. And as you can see, the number of cases is much higher, also because our testing capacity was much higher. And we look at the color zones being introduced. This is early November, and then additional measures being stepped up in Christmas. You can see there's a peak there. And then the change in the definition of the mitigation measures in May. Here we have our vaccination campaign starting, and here we have our prevalence of Alpha variant being detected in Italy. And locally acquired Delta variants, for example, were then detected as well, Delta Kappa. So in conclusion, I hope I showed you a little bit of the context in which the SARS-CoV-2 epidemic developed in Italy. Being the first country meant that a lot of the decisions were ice-breaking decisions. We really didn't have much to look at in Europe in terms of inspiration. The only country that had an experience at that time was China, and it was very different. Or places like, for example, South Korea, but they have a very different healthcare system, very different organization compared with the situation in Italy. The response approach was the hammer and the dance. And I hope I showed you a little bit how the data supported that strategy in an evolving situation. But the drawback is, because it was new, because we didn't know many things, it was very difficult to plan a long time ahead. And we've seen that, even in countries that have tried to plan ahead, this has sometimes changed, like in the UK recently. And then just to show you the kind of tools that were developed that was trying to help transform data into information. So I hope that was interesting, and I'm happy to take any questions. Thank you.
Thank you very much, Flavia. This was a very timely presentation in the conference. And this is one that certainly brought to the general public the importance of having science and decision makers working together to deal with this such a complex problem on which many things were unknown. Of course, there will be many questions, I'm sure, but I'll just invite you to take one from Elder Lima. If you can please read the question, because it's a bit long, and try to summarize it before you answer it, please. In the question, can you see it? He's asking, how do you see
the integration of data and information and off-the-shelf software solutions from private sector sources into disaster risk management, such as Blue Dot Company, which algorithm scours news reports and airline ticketing data predicting the spread of disease that goes linked to the flu outbreak in China. The company was able to send out word of the outbreak to its customers. Yes, this is a great point. I think it's in terms of the use of this type of information, it's not only in the private sector, also in the public sector. There is something we call epidemic intelligence. And part of that is called event-based surveillance, which means that we look at exactly this, non-conventional sources of information for the health sector. So yes, on the 31st of December was also when we received the alert, for example, from ECDC, from the European Center for Disease Control, and there were initial reports. So absolutely, I'm a big fan of epidemic intelligence. So I'm also because I'm part of the Italian network for epidemic intelligence. So absolutely, it's a great point. And one way we try to integrate this, for example, is also in the monitoring. We're looking actively at media, blogs, and Twitter and other sources of information to monitor the types of spread. So at the beginning, it was a lot about, where were the clusters? At the beginning, we didn't know much about this virus. So we were looking at how it was transmitted, which were the main areas. And now the focus is very much on the variants. So we're using this type of approach to support the traditional surveillance and data detection activities. And I think it's a great point. And I really hope that we will continue integrating these several sources of information to allow us to have the best picture in the earliest time.
Thank you very much, Flavia. I'd like to ask if anyone of our panelists want to add some
I have a question.
Final comment. Please, Daniela, go ahead.
Thank you. Flavia, at the beginning of your presentation, you talked about the initial skepticism of the decision makers with respect to the first scientific evidence and the first scientific opinion about the emerging epidemic and then pandemic. Do you think that this depends on the kind of the relationship that there is between scientists and decision maker in the health field, or why? Because we know this, we have this kind of experience in other risks, but for as far as it concerns the civil protection, our daily relationship with our research institutes and competence centers makes us put us in the position to be ready. If our scientific institutes tell us that there is a problem, we operate immediately because we know that they are reliable. So which was the problem in that moment?
I think the main issue was that this was new. And even the scientific community was very divided on whether this was going to be a problem or not. To be frank, I mean, until the end of January, there was, still no evidence. And even WHO on the 14th of January said there's no evidence of human-to-human transmission. Now, for a person like me, if there is no human-to-human transmission, the pandemic potential basically is not there. The other aspect is severity of disease. So at the beginning, the data that was available was for probably a very selected number of cases among the most severe, because that's what happens. Usually you see the most critical patients first because they're the ones that end up in ICU. They're the ones that die, so they're more visible. What we later learned that there is the majority of cases that got this infection are people that either have no symptoms at all or have very mild symptoms. And those were completely not identified at the beginning. There was a huge debate on whether there were asymptomatic cases and whether these cases could transmit. So I think the main issue is, I think what Professor Cocco said before, it's uncertainty. And it's really hard to veiculate and decide when you have scientists on the other side that basically tell you, I'm sorry, I don't know. And I think this was the thing that made that decision making, I think, sometimes discussed, because some people would say, it's better to be safe then sorry. And then there's other people saying, but look, you know, other countries are denying this is going to be an outbreak. So why are we declaring an emergency? And of course, and they're all valid points. So I wouldn't say it's about trust. It's about the fact that this was a new virus. And sometimes I think at the beginning, when we also spoke to the media to say, you know, this is a new virus, this didn't really come home as the seriousness that it was. It's new. We don't know it. We have to learn about it. And as we learn, we will let you know how it goes. So that's why it was, I think, at the beginning, difficult to make decisions, because really there wasn't much data, and you could interpret that data in different ways, and you would be right with the data you had at the time. If we look back now, of course, our vision is completely different.
Flavia, this is
Thank you.
related to the previous question of Daniela. We saw throughout the world many different reactions from different countries that took different ways. Was this due to differences in scientific counseling or on the perception of the decision makers and politicians? What's your opinion?
Well, I mean, as I said before, scientific evidence was limited. So you had to make decision on with a lot of uncertainty. And of course, it would depend on a number of elements. I think also of the population involved. You know, the sensitivity of the population, the sensitivity of the ruling part of that population. But I still think that, you know, there was a lot of scientific debate, and a lot of that debate was on TV. Which brings back to what was talked about before. You know, I think this, in a way, was good. It was super transparent what was being discussed. I think it also generated a lot of confusion. It wasn't maybe the easiest way to gain trust on what you were discussing. And so I was very surprised. I mean, opening the TV in January, February 2020, I felt like I was in a scientific conference, but it was actually a talk show. And that's the type of thing. So I think it was about context, it's about situations, and it's about risk perception. I think there was different risk perceptions in different countries. A bit of it has to do on your, on your knowledge of the strength and the weaknesses of your healthcare system. I believe that, you know, some colleagues, I was very surprised at the beginning of the outbreak. There were some colleagues from other countries that had interactions within Europe. They were telling me, you know, we don't have ICU, capacity to withstand this. We have to lock down. It's about knowledges of your strength, of your weaknesses, perception of risk, and all these things come together. And it doesn't always mean that you come to the same conclusions.
Okay, thank you, Flavia. I don't know, Massimo, if you want to say something.
Yes, Domingos, thank Andrea, do you want to go?
No, please, Massimo, go ahead.
No, I think that, what Flavia just presented is very, to me, very illustrative of an issue. First, the role of the media, because it is clear that we are dealing with the communication. So communication is present at different level with different structure in all the three interface between science and society, science and decision maker and society. However, the way in which this communication is modulated is mediated by the media. And here the issue is also, if we discuss about a cultural change, we need to make clear that the media, they have a role, they are the mediators, they are not out of the game, they are not independent, because they are part of also of the cultural change that we were discussing before. The other example that I would like to mention is that risk perception, of course, it is difficult to be measured and assessed. The civil protection in Italy tried many times. I know those attempts for the seismic and volcanic crisis, but they are. And again, risk perception can be modulated, and therefore there is a time dependence of risk perception. And sometimes when you have the emergency, the short-term perception overcome on the long term. This is again a way in which the highest is the preparedness, so therefore the resilience of the society before the emergencies occur, even if in the case of the pandemic, as Flavia Riccardo shown, was unprecedented, because what they did was decisions on some things that never happened before. But of course, I would like to raise these 2 points. First, that the role of the media should be taken into account because they are the acceptance level of the risk about the society is modulated by the media. And the second one, that the difficulties of communicating the uncertainties is not only technical, but because again, it is the literacy of the society to make clear how to manage the uncertainties. So if during an earthquake in Italy, we still have newspaper articles discussing about 2 magnitude differences of 0.2 between 2 research organizations, means that the awareness level and the preparedness is low. So this is a KPI that we don't have much. So if the discussion is discussing about the tiny difference in a magnitude estimates and not on the real application of the actions to mitigate the risk, this means that we are still far away. So disseminating and explaining the uncertainties, it is difficult because it's not a two-way dialogue. And as soon as you take decisions, as we have seen for the COVID, and these decisions are somehow explained to society by somebody else, which is a journalist, I think that we are a communication channel which is not completely under control, and this is the real difficulty. I am nothing against the media. I am in favor of communication and transparency, but I think that the media itself should be aware that they have a role, and they are not the minor actors for risk perceptions. And this entered also in legal prosecution and trial. We already experienced this. So this is not a secondary issue.
Thank you very much, Massimo. And we are now coming to the end of our webinar. From my part, I would like to thank once again to all of you that attended and participated in this webinar, and to the speakers in particular. If you allow me, I'd like to give a special thanks to the members of my team, ADAI, who supported in the preparation and the development of this webinar. A word of thanks to them. And now to close the webinar and to say some final words, I leave the floor to Andrea Prote, the coordinator of our roadmap project. Please, Andrea.
Domingos, thanks. I'm very happy about this webinar because when we planned it, we had an idea, but I think what came out, at least for me, was really amazing. Very interesting presentation. Also, I noticed the participation of people through the messages. We hope that maybe some future comments will come to us. Maybe you think about the presentations. You can watch again this webinar. I remind all participants that Luis Ribeiro sent a message, so you have a link of YouTube. You will find it also on the roadmap website. So please, if you missed something or you want to view it again, you can do that, or you can spread the news among interested colleagues. I would like to thank all speakers, all participants, and please let me express my special thanks to Professor Viegas and to the group of ADAI, because I think the organization of this online webinar, I should say, it was perfect, and this is very good. So we are a little bit out of time, but it was a very fruitful meeting. So have a nice day and a nice weekend, and we will see in the next meetings and opportunities. Thank you.